Hello all, and welcome to today's webinar, From Identification to Intervention, How IntegrateBH Closes the Behavioral Health Gap in Population Health. We're so excited to have you joining us today. This webinar comes on the heels of our announcement of the expansion of our IntegrateBH solution, and we're excited to talk more about the solution and why we believe it could be invaluable for your organizations. We'll start with a few slides situating us all on the IntegrateBH solution, followed by a demo of our referral management capabilities by Michael Schmeider, our SVP of Product. After, we'll get the opportunity to talk with Julia Orlando, our partner at Bergen Newbridge, and learn how IntegrateBH led to real clinical and financial outcomes for their organization. We will have audience Q&A at the end. Feel free to send questions throughout the webinar. We'll address them at that time. If we aren't able to get through all the questions, we will be able to follow up afterwards. We'll start with some quick intros before we jump in. I'm Parker Warner. I'm a senior product marketing lead here at NeuroFlow. I have spent most of my career in healthcare, started out in healthcare consulting, and I've been with NeuroFlow for just about 6 years in a variety of roles related to strategy, BD, and go-to-market. It's been really incredible to be on this journey with the NeuroFlow team, and I'm excited to share with you all some of our more recent updates. Michael, I'll pass it to you next.
Sure. Thank you, Parker. Good afternoon, everyone. Michael Schmeider, Senior Vice President of Product at NeuroFlow. I've joined the company just over a year ago from Quartet Health. My background, I've spent the better part of the last 20 years in healthcare, technology, and services, as well as managed care. Prior to Quartet and my time in the behavioral health space, spent a lot of time focused on post-acute care and working on the intersection of physical health and behavioral health. Excited for walking you through some of the product demos today. Julia, I'll hand it to you.
Hi, I'm Julia Orlando. I'm the Vice President of Integrative Services at Bergen Newbridge Medical Center. We are in our second year of working with NeuroFlow and just very excited about the work that we've been able to do together for our most vulnerable populations here. Thank you.
Thank you both. Before we get into IntegrateBH, I wanted to spend some time talking about some of the problems that we've heard from many of you and other systems like you. Behavioral health management is hard, and we know that not having the proper systems and intelligence can lead to many operational challenges, which ultimately leads to directly impacting the financial health of your organizations. We see 3 core challenges that consistently come up in our conversations with health systems and that we're poised to address. First, unidentified behavioral health risk. Behavioral health is often managed in a silo at many organizations, and screening can happen infrequently, often only at an annual visit, and this leads to conditions going undiagnosed until they escalate into an ED visit or an inpatient admission. Think about your patients with comorbid conditions, diabetes plus depression, heart failure plus anxiety, where unaddressed behavioral health is quietly driving up the utilization and leading to poor outcomes amongst these populations. This unidentified risk leads to poor performance on quality metrics and excess acute care utilization, using up really valuable beds. Second, resource allocation challenges. Even when patients are identified who need behavioral health support, the system doesn't always route them intelligently. Wait lists can grow, patients get matched to the wrong intensity of care, and many simply fall out of the funnel entirely. EHRs do a great job of documenting what happened, and they can give you basic referral infrastructure, but they're not telling you which patients are likely to engage, who's drifting toward disengagement, or how to match those unfilled referral slots to the right level of care. You're filling appointments with patients who might not show up, while the ones who would benefit most don't get connected. When behavioral health resources aren't being utilized efficiently, this can lead to poor clinical outcomes, and you may be missing out on important behavioral health revenue. Third, administrative burden. Care teams are drowning in a lot of manual work, screening workflows, documentation, chasing referrals by phone and fax, trying to monitor progress without any automated signal. Beyond the manual work, we know that behavioral health shows up across the system, not just where individuals are trained to manage it. How are these individuals managing that behavioral health without the proper tools? Sometimes they aren't, and that's not sustainable. This isn't how we want our clinicians spending their time. When behavioral health is managed using some of these systems, you might be forfeiting bonus dollars for meeting screening metrics or dealing with costly retention issues among your staff. These three challenges are interconnected, and they're driving costly downstream impacts: avoidable ED visits, unnecessary inpatient stays, and poor outcomes on value-based contracts. This problem set is exactly what IntegrateBH was built to solve. I want to talk a little bit about the NeuroFlow journey because IntegrateBH is really a natural evolution of our product over time. NeuroFlow's core has always been about bridging the divide between physical and behavioral health care. We've invested in our product over the years, both through organic and inorganic growth. Our platform really started and grew from addressing integration into primary care through enabling models such as collaborative care. This core infrastructure created both a patient and clinician-facing experience that identifies and measures behavioral health over time while providing patient engagement and education through Onward, our patient platform. As we grew, we invested in our measurement-based care infrastructure through multiple acquisitions and investments in patient outreach. These investments led us to expand our library of validated instruments and improve our patient engagement infrastructure, simplifying the way that patients take assessments, all with the goal of ensuring better measurement and stratification of large populations so that care teams can track outcomes in real time rather than flying blind between visits. From there, we have expanded into additional service lines, moving beyond primary care integration and into specialties, transitions of care, and population-level programs, where behavioral health signals matter just as much. We know that behavioral health is driving poor outcomes and physical health conditions across the system. One example of this, we work with clients like Christiana Care to create custom maternity programs that unlock additional revenue opportunities and overall improve clinical outcomes. And most recently, through our latest acquisition, we've been able to close the loop from identification to care with our referral management capabilities. We're combining clinical signals and patient engagement to not just predict clinical need, but to route patients into tailored clinical pathways based on real capacity. Through this natural evolution and growth, IntegrateBH has become the intelligence and orchestration layer that works alongside your EHR to effectively address behavioral health across your system. Now that I've given you a little bit of a preview already, I want to talk through IntegrateBH in a little more depth. At its core, IntegrateBH unifies risk identification, intelligent referral matching, and care coordination, enabling health systems and health plans to scale behavioral health management. Starting with the integration-led architecture, IntegrateBH is meant to be integrated not only into your EHR and systems of records, but also into your workflows. IntegrateBH layers the behavioral health intelligence on top of the workflows your teams already use. This approach to implementation helps alleviate administrative burden and empowers your staff to take the appropriate next best action. Implementation like this requires deep discovery of your existing processes and configurability in our rollouts. At Bergen, this configurability was pivotal, ensuring that our rollout was successful and had that broad adoption. We're really working to give your programs and infrastructure the behavioral health analytical and orchestration capabilities they don't natively have. Proactive risk stratification. This is about getting ahead of the problem. Rather than waiting for a crisis, we're continuously analyzing clinical and operational signals to identify patients who need behavioral health interventions before they escalate into costly ED or inpatient encounters. Especially for patients with comorbid conditions, early identification is the key to preventing these downstream cost drivers. This proactive approach ensures that you are meeting quality measures and enhancing appropriate throughput of your acute care settings. With IntegrateBH, we're doing more than just screening or identifying new individuals. We're making sure alerts are fired when necessary and keeping people out of the funnel when care is not required. At Bergen, these alerts allowed the clinical staff to prioritize follow-up and intervene in truly critical moments for patients. Intelligent referral management. This is the intelligent automation of triage and routing that allows us to close the loop on behavioral health care. I won't spend too much time here because Mike will get into this in more depth and be able to show you a bit of a demo. But I'm really excited about how this capability has evolved and how leveraging the experience and network we gained through acquisition, along with the NeuroFlow infrastructure, has created a truly complete solution. Last piece I wanted to talk about, automated program execution. Reducing administrative burden on clinical teams through rules-based triggers for screening, referrals, and program enrollment. Once a patient is routed, IntegrateBH manages the program delivery, monitoring adherence, surfacing disengagement signals, and escalating when a patient's trajectory changes. One use case here is transitions of care, making sure patients moving between settings don't fall through the cracks, especially those high-risk patients who need behavioral health follow-up post-discharge. This is what takes the administrative burden off your care teams and lets them focus on the clinical work rather than manual tracking and follow-up. Together, these 4 capabilities and pillars give you the behavioral health infrastructure layer that sits between your EHR and your clinical programs, the intelligence and orchestration that actually makes behavioral health operationally sustainable at scale. All right. Thanks for letting me kick things off with a little bit of background and overview of IntegrateBH. I'll now pass it to Michael to talk through referral management in a little bit more depth and give a quick product demo.
Great. Thank you, Parker. So before I get into the demo, just a little bit of level setting on our referral management capabilities. So it's a natural extension and core part of our IntegrateBH product. And it's really powered by 4 main capabilities. The first being our identification engine, which is all around how do we help our customers maximize the identification of patients with an unmet behavioral health need and continue to drive engagement and ultimately get them into the appropriate level of care and provider of care. We do this through our omnichannel assessments. We also have a digital intake experience, which we'll show you today. And then we have our retrospective analytics, which helps our customers get super targeted on the populations that they want to engage. Next being our AI-driven matching. So we have a provider matching algorithm. It's a machine learning algorithm that looks at specific unique patient needs, personal preferences, their clinical need, and then we look at the network of providers that are available to service those patients' needs or that patient's needs. And then we also look at making sure the recommendations are quality providers. So we're looking at providers that have high scheduling rates, high acceptance rates, are confirming appointments and adhering to appropriate follow-up. All that data comes into the algorithm and we make real-time recommendations as patients are referred through our platform. The next capability is care navigation. So we push digital first. There are a large percentage of patients that will be referred by a clinician or provider, and they'll be able to go through this experience on their own, triggering the AI-driven matching, what we call smart match, selecting a provider, and then going on to schedule an appointment with that provider. However, there are a percentage of patients, typically higher acuity patients or maybe providers that are working with a pediatric population that require additional level of support. And that's where we do offer care navigation services. These are both clinical and non-clinical resources that are available. If a patient is going through the experience and would like to talk to a care navigator, they have the ability to do so and request a callback. This team of care navigators is also monitoring each of the referrals that come through on the back end. So they're doing follow-ups. They're making sure if there's a missed appointment or if we didn't get confirmation that the patient attended, they are following up directly with the patient and the provider. The last piece is the network. So we do bring a network to our customers. We also have the ability to onboard an existing network. So if you're a health system that has integrated behavioral health providers that want to be a part of the referral platform, we can onboard those providers so that our matching algorithm is matching to them based on the patient need. We could also set what we call preferential matching, so that there's a hierarchy of providers that would get recommended for patients, again, based on their clinical and personal preference. But then we also have provider partners. So we will do a full network analysis. We'll bring provider partners to you and partner with you on onboarding them to our platform. And we'll do the heavy lifting and ensure that they're trained on the platform and that it's a seamless integration so that they're part of our referral network. As you can see, where we have implemented these services to date, we've seen significant improvement in reducing the time to care or speed to care. So making sure we're referring patients, we're recommending providers that have timely availability that meets their personal need or clinical need. And we've seen reduction from anywhere 14, 21 days down to below 10 days with availability for appointments within 24 to 48 hours. And then lastly, we've seen a significant increase in the likelihood of patients to schedule and actually get into care with a behavioral health provider through using these capabilities. What I'm going to do now is walk you through a demo of how we're enhancing our referral management capabilities as part of the IntegrateBH product. Okay, so the first piece that we're going to walk through is the provider enablement components. So this is a demo environment. What I'm walking through here is an illustrative visual of what this could look like in your EHR. Now, all EHRs are a little different. This example is using the best practice advisory capability, which is native to Epic. Many of the other EHRs like Cerner and others have very similar clinical decision support tools, rules, and prompts that can be configured. What NeuroFlow does is we bring the expertise through our integrations. We're making sure that your system has access to all the data you need from NeuroFlow, whether that's through our assessment capability or referral management, so that you're able to bring this into the EHR and make it a part of the provider's workflow. So the look and feel may be different based on your system's actual implementation, but our resources will work with your teams and make sure that not only the visuals, but the clinical rules and the prompts are configured based on your system and your practice specific needs. So in this example here, I'm going to walk through two patients. The first patient, as you can see here, you have the BPA or the best practice advisory recommendation at the top in green. You can see the NeuroFlow behavioral health results coming into the EHR, where you can track this patient's PHQ scores over the last 6 months. And you can see in the recommendation, based on how this patient scored, their mild severity, and we would recommend self-guided behavioral health support. So in this example, the provider can see the results coming in. They can click to respond to the action or to the BPA here. Now they're getting a next screen, which gives them a little more detail on the recommendation. Again, in this example, patient scoring on the mild side, we're recommending self-guided support. And of course, at this point, it's up to the provider's decision on the next best action for this patient. We would recommend enrolling them in the self-guided support, which would lead to a registration with our Onward DCBT app. Provider has the example to send the registration to NeuroFlow. They may also want to schedule a PHQ follow-up within 4 weeks via NeuroFlow. They're going to click accept. Now at this point, that patient is going to receive a text or email inviting them into the onward experience and registration with the app. And they'll get that notification, like I mentioned, via text or email, and then they'll also get a 4-week follow-up on the PHQ. I'm going to go back to the chart. And now this example I'll walk through. As you can see, the BPA's changed colors. This patient has scored higher on the PHQ, triggering moderate to severe acuity. And here's where we're going to recommend a referral for behavioral health support. And I'll kind of walk through that experience. So again, at the BPA line at the top here, they'll click to respond. You can see additional information on the recommendation based on the scoring. Provider has the ability to now select and order a BH referral, or they can acknowledge this and not submit the referral at this time. We're going to click Submit BH Referral. In this example, again, this would be configurable. The provider has the ability to check off an ambulatory referral for outpatient BH services, or if there is an existing COCM program, they could also flag for the identification for collaborative care. I'm going to click on the ambulatory referral, accept and sign. So at this point, patient has now been invited to the experience. They're getting a text message inviting them into the digital, what we call our digital intake. We've collected consent, and as that's been documented, which is then allowing us to trigger that SMS notification. And now I will flip to the patient experience. So everything you just saw led to now a patient opening up on their smartphone. They're getting an SMS message inviting them into the experience. This is something, oops, I'm sorry, you guys can't see that. Okay, I apologize. So now we've moved to the patient experience. This example, they're getting a text message on their smartphone. Here's an example of what that welcome text would look like. We would, of course, partner with you to configure any co-branding or what the specific language would be. They would click the link. We're going to validate who they are. So we're going to do the validation based on their date of birth, language. Now we're going to start collecting information that helps us run our algorithm and making sure we're going to recommend a provider group that meets not only their clinical need, but also any personal preferences they may have. So the first thing is just understanding where they want to focus or what their specific need may be. And again, this is all going to help the algorithm to make sure we're making very specific recommendations. So after we ask for the 3, we're just looking to understand what's most important to this patient based on their need. Okay, so I'm going to click depression. Now we want to ask the patient, what kind of support are they looking for? Talk therapy, family therapy, med management. We also have the ability to configure additional evaluation or diagnoses, or diagnosis, I should say. For this example, we're going to select talk therapy. And again, each of these questions we're asking is feeding into our algorithm, again, as we look at our behavioral health provider profiles, which are set up in our system. The algorithm's looking at that information, and it all takes into account which providers we're going to surface at the end of this experience so the patient can schedule. We'd want to know if they have any preferences on meeting their provider. Do they want in-person? Do they want the flexibility to have in-person and virtual? Or are they very specific to one or the other? I'm going to select in-person for this example. Next, do they have any preference on gender identity for their provider? Any language preferences? We're going to validate the address. So we want to make sure what we have on file is where the patient's currently located. This is especially important if the patient's looking for in-person care, as we're going to look for providers that are within proximity of where the patient resides. Okay, so at this point, we've collected the information we need. We received the assessment scores from the provider directly through the EHR integration. We received the trigger for a BH referral based on that BPA recommendation that was displayed to the provider directly within the EHR. The provider then triggered the outpatient referral, brought the patient to this experience. We've collected the additional information to now run the algorithm, and now we are making provider group recommendations based on the specific information that we've collected through our intake process. So this is an illustrative example where we've got 3 provider groups. Again, a lot of this is configurable. We work with these providers on a regular basis. We would work with your providers to make sure we have the detailed information we need within their profile, which would help the patient as they're looking to select a provider of choice and schedule. In this example, we are recommending their top or preferred match would be a provider within ThriveWorks. When they're ready to request the appointment, they would click request appointment. That referral is now going out to that provider who's connected to our platform. So they are getting a notification through NeuroFlow. They have a new referral where they have the ability to review and accept that request and then follow on directly with the patient for scheduling. You'll see here, in addition to triggering the referral to the BH network, we're also providing the patient, if they have not done so already, with the ability to register for Onward at the end of this digital experience. Okay, so they can hit Get Started. It would take them through the registration process for Onward if they weren't already a registered user. I think the last thing I also want to call out, you may have noticed this Talk to a Human icon up here, or button. That goes back to care navigation. So at any point in this experience, if the patient has questions, wants to talk to somebody, they can click that button and a care navigator will get that notification and they'll follow up directly with the patient to help them through this process. Okay, so with that, that concludes the demo for today. Again, this is a capability that's core to IntegrateBH. We're using this today with several customers, and a lot of what you're seeing today is how we're continuing to enhance this process and also get deeper with our integrations with health system EMRs to streamline that process for providers and drive efficiency and automation within their workflows. So I know we're going to save some time at the end. I'm happy to answer any questions at the end of the webinar, and also we'll make sure everyone has my information and happy to follow up afterwards offline. So with that, thank you. And Parker, I think I'm handing this back to you.
Thank you, Michael. All right, well, with the remaining time, we'll be able to talk with Julia Orlando. I have a couple of questions for Julia, and then at the end, we will open it up to general audience questions. Again, you can submit those questions through the GoToWebinar platform at any time. All right. Julia, thank you so much again for being here today. We're really appreciative of the opportunity to talk through your program. I'd love to start with some background. Before NeuroFlow, what did behavioral health screening look like at Bergen? What challenges were you encountering?
So we launched NeuroFlow in our ambulatory care clinic. And within that system, people were getting annual screenings for suicide, for depression. But with this new service, we are actually capturing any kind of changes for a person, either in mental health or in any social determinants of health, actually before their visits and in between visits. So any kind of changes that are coming up with that person, we are going to be able to see. What this allows us to do is really break down silos of care for patients with complex conditions all in one place and actually improve access to care. So for example, we're doing assessments that include, in addition to our PHQ-9, we're doing Fagerstrom, we're looking at people if they're struggling with smoking, if they have any kind of food insecurity, if they're having trouble with transportation. And why all of those things are very important in this clinic setting is because if any of those issues are actually causing any kind of lag or an obstacle to their care, it's going to get picked up and addressed through NeuroFlow. And in addition to that, you might have people who have mental health symptoms that are also impeding on their ability to follow up on treatment and care, and we would be picking them up now through this process.
Yeah, that's great. I know beyond the clinical and just patient impact that this program has had, another driver behind this was the quality program, QuipNJ. Can you tell us a little bit more about that program and how NeuroFlow's digital screening helps support that quality initiative?
Sure, and I'm going to give people a little bit of background because you might be thinking, I don't know what that is. So QUIP New Jersey is a state-run hospital funding and performance program that's designed to improve the quality of care while supporting financially strained hospital systems, especially safety nets like Bergen Newbridge Medical Center. And it's a supplemental Medicaid funding that ties the funding to quality and performance metrics. And some of those metrics include clinical quality and outcomes. So for example, are patients getting better? Utilization and efficiencies. Are we using the hospital appropriately, right? So that's looking at our emergency department use and throughput, length of stay issues. Behavioral health and integration follow-up after hospitalization, including substance use treatment, looking at how we are attaching people to that care. Population health and social drivers. So that's looking at things like, are we managing populations and not just episodes? Access, equity, and disparities. So who are we serving and how well are we serving those individuals? It looks at patient experience. And lastly, it looks at innovation and transformation projects. So are we building new models of care like NeuroFlow? So NeuroFlow is an example of the kind of innovative model of care that's helping us get this care to individuals. So it's allowed for whole person care in utilizing a tablet, right? So through this tablet, this allows us to access patient need outside of our walls. So for example, before someone even comes in for their appointment, they're getting an assessment and they can fill out that assessment. And I'm going to give you an example a little bit later on of our ability to actually intervene with someone we haven't even seen yet. And that's not something we were able to do before working with NeuroFlow. So for us, it's not just about collecting data, but it's about improving the standard of care.
Yes. In terms of the data collection and increase in screening rates, 14x is a pretty large number. Can you walk us through what some of those operational changes were that had to happen to make that possible?
Sure, and speaking as the person who was running point for this in our hospital, number one, you have to make sure everyone's involved. This is not just, it didn't just involve the ambulatory care clinic, it involved a lot of pieces in the hospital, a lot of people who really on every service line were involved from the beginning to implementation. And I think what we did was smart, which was we started small. We started with 2 primary care doctors and having a physician champion located in the clinic, I think really helped. Somebody who speaks their language, who could help, address any concerns that they might have. I think that was really helpful for us. We also had 2 of my team members from clinical integration in the waiting area. So while people were using the tablets, and let me just say this, that using the tablets, the data showed us that people were much more honest when they were responding on the tablet than they were if they were responding to someone in the clinic asking them the very same questions. So people using the clinic, making sure if they needed it in a different language, if they had any questions, having that team in the waiting room, helping people navigate that, Also help them deal with any anxiety they had. Why are you asking me these questions? So we found that to be really helpful. Also, the SMS text that was pre-visit was very, very useful. So people that were able to answer those questions in their home very honestly, let us know before that person even came in if they had an elevated score, if this was someone that the doctor maybe had to ask a few more questions of. So it just gave so much more information. We also found that the weekly calls with the NeuroFlow helped us work through any issues. Like in the beginning, there's all kinds of things that don't work or concerns around slow down of especially in a busy clinic like ours. You want to address anything right away. So having NeuroFlow on the horn with us every single week, fixing any issues, fixing any concerns, really helped for us to keep our numbers going up. And then last, I would say, is senior leadership. Having senior leadership support in the hospital, talking about it on our calls, on our manager and directors and everyone, because everybody's like, what's NeuroFlow and how can we have it here and not here? And helping people understand why we needed to support this and why this was so important. I think that was a very large factor in why our data was so successful.
Yeah, I love hearing how things evolved over time and the multimodal approach that was used to address the different populations. It's great. Whenever we talk, Julia, you always have some really impactful stories and talking about specific Bergen patients and individuals who may have otherwise gone unidentified. I'd love for you to share one of those stories with the broader audience.
Sure. I actually have a couple because I felt like they were showed different ways in which this was helpful. Going back to having the assessments for someone before they're seen. We had a gentleman who was actually going to be seen by a specialist, and it was a Friday night at 7 p.m. and he said something on the assessment that was concerning, and NeuroFlow team got the alert. They alerted our team. We were able to reach out to that individual and connect him to care immediately. And that does not disrupt, his appointment with the specialist. He was still able to do that, but we were able to intervene, really quickly and effectively. So I think when people are afraid of AI, it's not replacing the person. It's not replacing the person that's going to jump in and help. It's really the alert system. It's saying, okay, this person's using certain words that indicates there's an alert going on. So we're going to let those people know so that they can reach out and do what they do best. And I just think that's a great example. Having a nurse practitioner in the role at NeuroFlow within the clinic has made a big difference. Her intuition and her assessment skills are outstanding. And we did have an example of a woman that was being treated within our clinic who stopped taking her medication. And the doctor was very concerned about this and said, you know what, I'm going to have the nurse practitioner reach out and find out what's going on. Well, through her very good assessment and developing a rapport with this patient, found out that the patient was stockpiling medication to suicide. And we were able to intervene, get her to crisis care immediately, and then get her back on track with her physical needs and get her back on track with her medication. So this was just such an example of something that we would not have had that before. It might have resulted in a referral to behavioral health that might have taken some time, but this was in the moment. And us being able to provide this kind of care really breaks down silos, right? We're able to attach people immediately into that care. The last example I'll give you was one that I was involved with myself, where a nurse practitioner just really something wasn't right, and really felt like I need someone to kind of help me out here because I can't get to where the issue is. And myself and our chief of behavioral health met with this person, and what it was actually very, very serious domestic violence that was going on. She had a lot of concerns about expressing that, and we were able to actually find an intervention that she was comfortable with and felt safe to talk about that. So those, I think, those three examples, I think, really illustrate that on so many different ways, the NeuroFlow has, our partnership together has been able to help us with people in ways I don't think we ever imagined before. So we're still doing the outstanding clinic work, right? We're still seeing people and addressing medical needs. But to have this very convenient, efficient way to immediately address not only behavioral health, but also social determinants of health that affect our physical health has been incredible.
Thank you so much for sharing those stories. I think it's so important to remember that the numbers on the screen are actual people, and that we're all in this to support those patients. So appreciate that. Speaking of patients, I know that Bergen Newbridge serves a very complex patient population. How did this program and working with NeuroFlow adapt over time to fit that workflow, your specific care team structure, and needs of your patients?
I think that's a great question. I think we were a challenge for NeuroFlow. We often describe ourselves as a unicorn. We're very unique. We're the largest hospital in the state of New Jersey, and I don't think people always realize that. And we had a lot of challenges, particularly with our medical record. And we had to find an innovative way to be able to figure out how information was going to go in, where the doctors were going to be able to document. And so NeuroFlow adapted to our program to fit our workflows. We figured out how to make this work because, so for example, if the information wasn't done through a tablet, it had to be manually input. And so, we had to work that out, figure out what that looked like. And like I said, those weekly calls were very successful, even in the beginning when we were even having trouble finding staffing. This is a new kind of work to have, whether you're having social workers or nurse practitioners working in a medical setting, and yet doing behavioral health, right? And so helping us, giving us good advice along those lines, I think was particularly helpful. We had experts throughout NeuroFlow in different ways to help us really work through our challenges. And we're very patient with us. And we're excited because our hospital is actually in an epic migration. So we've just started that, and we will complete that by February of 2027. And, we anticipate that this will look very different. But their willingness to work with us and to figure out and problem solve where we are now really enabled us to use this service without really having to sacrifice anything. And I feel like that's we really appreciated that support.
We appreciated your all's willingness to work with us along the way as well. I do have one final question for you, Julia, before we open it up to audience Q&A. Looking ahead, are there areas where Bergen's looking to expand behavioral health programs and potentially expand the use of NeuroFlow as well that you'd like to talk about?
So we're always looking to expand. We're always looking to innovate. For us, it's really about making sure that everyone has access to care. Everyone has access to quality care. And so that really is at the heart of everything that we do here. I think one of the things I'd like to say that we've talked about is, we are expanding our emergency department to 29 new behavioral health rooms, and that for us is it's very close to actually launching. And when I look at what NeuroFlow is going to do for us, is you could look at that and say, well, it's a behavioral health ED. Why do you need NeuroFlow, right? I think where the real value is when people leave our ED, and even if they're leaving with appointments and we've done assessments, being able to have access to that digital platform, whether it's through journaling and through all the different activities you have there, it's almost like we're able to continue caring for the patient in between those visits, right? because sometimes people can leave and maybe being able to do that prevents them from coming back. It prevents a readmission because we're able to identify that. So I think for us, that's something, you know, we're looking at, if there's a way to kind of take the work that we're already doing, because it is a behavioral health ED, but bringing in the ability with AI and that platform to really help care beyond the walls here and help people really every step of their journey. So that's one of the things we see.
Yeah, I love that. I think supporting people during those critical transitions is so important, and really excited to continue to work with you guys to support you on your behavioral health ED.
Thank you.
Awesome. Well, at this point, we'll open it up to audience Q&A. Feel free to continue sending in questions, and I will direct appropriately. All right. Michael, this first question is for you. What information drives the smart match algorithm?
Yeah, so as I was mentioning earlier, so the smart match algorithm is going to look at the data we collect from the providers making the referral, whether that's integrated, the assessment results coming through the NeuroFlow platform. It's going to take into consideration the patient inputted data, so their personal preferences, you know, what they're looking for, type of care, provider of care, any you know, gender identity preferences. There's also, we didn't see this in the demo, but there's also in the intake, there's areas where we do collect free text options. So things like religion, race, etc. If there's any preference there, that all comes in into the platform. The algorithm's looking at that data. On the other side, we have data on the providers that are connected to our platform. So every provider group that we onboard, we work with them on how many providers do they have, what are the different specialties, the ages that they treat. So all that kind of goes into the profiles on the back end. And that data is a part of the matching algorithm as well. The last piece is, if there's any other data, if working with a payer, if there's claims data or a health system, if there's EHR encounter data, we can also leverage that information to support the provider matching in terms of which providers would get recommended based on some of their performance and the data that we can pull from claims or encounters. And then the last piece is what we call our product data. So as we're using these providers in different markets, and we're going to make recommendations that are in network with the patients that are getting referred. We're going to make recommendations that match, like I mentioned, their clinical need, their specific preferences. But we are also collecting product data on a almost real-time basis with these providers. So we know when they accept a referral, how timely that is. Are they accepting referrals within 24, 48 hours, or are they taking longer to accept? That's going to impact where they show and where they display in terms of the ranking as part of the algorithmic ranking that is a part of that process. And then the last piece would be scheduling and actually getting patients to attend appointments. All that information we collect, and it's taken into consideration by the algorithm as we're making those recommendations. The last piece, which is a little maybe not specific to the matching algorithm, but I do want to acknowledge, I might have missed this in the demo, that product data and that information we collect from the behavioral health providers that are engaging and scheduling appointments and ultimately treating these patients. We collect that information, and that will go back to the referring provider, either through our platform or ideally through the integration. So those EHR screens, again, those were specific demos of one example of how this would be implemented. You would be getting that information back in terms of when did the patient schedule the appointment, who is the provider, and then eventually did they actually attend that appointment.
Great, thank you for that additional detail. Julia, we have a couple questions for you, a little bit more specific about the Bergen-Newbridge use case. The first one is around if the initial screening is done on a dedicated tablet during intake, and if so, how does it get imported into the practice chart so the practice gets credit for the screening? And can this be integrated with other pre-existing tablet-based protocols that you may have in place?
So how does the question is, how does the initial screening
from the tablet during
Right.
intake get into the chart so that you get credit for the screening?
So this is a technical question. I think it's a technical. I don't know that I can necessarily answer that question. I'm just going to look here. So hold on. So I do know that if it was entered into the tablet, right? So that's going into, it went right into the patient chart through ADS. But if it was verbal, right, then that had to actually get put onto the dashboard that NeuroFlow helped us set up here.
Yeah.
I hope that answered the question.
No, yeah,
I think I wasn't going to get a technical question.
No, I think part of that was done through you got it right, through integration into the EHR.
Yeah.
I wasn't sure if there was anything a little bit more workflow related.
I hope not. Okay.
Touch on, but no, I think that is great. And then another question for you, just around you mentioned this a little bit, but around NeuroFlow's urgent and at-risk alerts. How is Bergen utilizing those in their workflows?
I think that's a great question. And the thing we had to figure out really quickly, because this is a medical environment. So even though we have world-class behavioral health services here, what happens is when you see, especially a high alert, everyone panics. Everyone's like, oh boy, so what are we going to do now? And where this becomes a challenge is we had situations where you have a person, they come in, they're here for an hour to see a doctor. And now you've got them and you're concerned about them because they've said some things that are concerning. So you're kind of in a situation where you can't really let them out of your care at this moment. But what we found was where you normally say, okay, well, maybe we have to bring them to the emergency department because this is urgent, right? Think about this. If you're a mom and you have childcare and you got to get your kids at school, how are you managing this? Like now all of a sudden you've got this panic and so what we learned was it was very, very important once an urgent alert happened that we had our clinicians, if this was in person especially, sit with the person, talk with them. And what we found is that if we took the time, if we really listened to what was going on, it most likely, in most cases, we could have that person come back the next day, when they could make childcare. So you have to be really thoughtful because this is a practice. So you want to retain your patients, you want to give them the best care. You have to really think about if this is an urgent alert, really what that means, how are you addressing it, and be really careful. Because I think initially we were like, oh boy, this is, they're saying all these words. And so we've got to do, this is what we normally do. And we realized that we really had to recreate how we were responding to, and there's a difference between, high risk and an alert, right? So people who were really scoring high, we needed to respond immediately, but really be thoughtful and accommodating whenever we could with that individual to make sure that we weren't being disruptive, because that adds more stress, right? So, we had one particular patient who had a disabled child they had to get to. And that's probably why they have an urgent alert, right? They have a lot of stress, they have a lot of things going on, a lot of challenges. So you have to respond, but you also have to be thoughtful, and you have to design your system really around the needs of your patients. And I think that was the most important thing that it really taught us.
Great. We actually have two questions about elderly patients or people who are not very tech savvy and may not be able to complete all the forms on their own. I'd actually be interested to hear from both of you, Julia, how you've handled this in some of the clinic settings, and then Mike, how we might handle this through the referral process as well.
So, I mean, I'll go first. I would just say that I think that's why having the option of a tablet and an SMS text, and then having the option is you can sit with us when you come in and you sit with our MA, right? You can actually have the questions asked for you. I mean, I think that's perfectly fine. I think having the options are great. Tablet is better, it's superior, but you have to make those accommodations the same way you're going to make accommodations for different languages, and being able to do that as well.
Yeah, agreed, Julia. And I think what I could add, when you look at that referral flow, that digital experience, we have worked with both systems and payers, Medicare Advantage population, and we've actually seen a very high completion percentage across the board, really, in terms of patients being able to go through that experience. The biggest barrier is getting them in, right? So opening that text, that email, clicking the link. Once they open that and they get through the date of birth validation, we see right about 90% completion rate of that intake form. So, we're seeing high rates of completion. That doesn't mean everybody that gets referred is getting into care by any means. We all know that's certainly a challenge, but I think that's where the technology supports it, digital first, but there is the human element. So I mentioned care navigation. Yes, they're going to follow up if a patient proactively wants to speak to somebody or wants to talk to a care navigator. They're also going to follow up after the patient's schedule to make sure they got into their appointment. The other thing that they're there for, and if this is something a customer would like, is our care navigation team. I mean, they're truly navigators. So they're looking at the referrals, and if they could see someone was referred but didn't engage in the intake or dropped off, that's where they can do an outbound phone call and look to engage that patient and just help them through the process. Figure out, hey, saw that you were referred by your provider, you didn't complete the intake. Can we help you through that process? It could be, a personal reason they didn't. It could be a clinical barrier, but that's where really the power of kind of care navigation. And again, it doesn't have to be NeuroFlow. We could help empower, whether it's a case management team or some of our customers have their own care navigators. And that's where we just want to make sure we present the data, the information we're collecting so that your teams can be efficient. But it's that, tech first, but there's definitely a human element of it.
Yeah, I think that's great. I think what both of you just highlighted is the high tech, high touch technology can help you be super efficient, but the human touch is always important in closing the loop fully. All right, we have just about 2 minutes left, and so I think one more question we can get through. Michael, this one's for you as well, around vetting providers recommended in the platform for referrals.
Yeah, so we have we have a network management team, and their job is they aren't necessarily a contracting team, but they are working to engage with these providers. They work very closely with our customers. So if our customer is a payer, they are working to make sure we're looking at their in-network providers, their BH providers. We're doing that network analysis to make sure we're targeting the specific providers and helping them with the onboarding process. But it doesn't stop there. They're going to continue to monitor their performance. The more access we have to kind of clinical data, we can help partner with our customers in terms of who are the providers that we're seeing quality outcomes. But at a minimum, we're going to look at their engagement on the platform. Are they accepting referrals? Are they getting members into care? Are they regularly engaging and sending updates? For a health system, it's very similar. So we'll work with our customers if they have internal integrated BH providers. We're going to do the same thing to support that group with the onboarding, the training, and then again, it's kind of the ongoing management. But it's very much a partnership approach. So if there are providers that, aren't performing well, if we're getting patient complaints, we have a whole team that works through a process to make sure the providers that are onboarded are using the platform and they're driving outcomes to support our customers.
Great. Thank you for that explanation. And really appreciate both your time, Julia and Michael, and everyone for joining us here. And with that, we will close. Thank you.
Thank you, Julia.
Thank you, Michael.